continue on. Abdominal and genitourinary trauma or injury. Okay, if you remember back to the human body chapter when we talked about anatomy and we talked about abdominal anatomy, the abdomen is divided into 4 general quadrants, and it's important, extremely important, for you to learn what is contained within each one of those quadrants, so that when you have a patient with abdominal trauma, you can determine what structures may be involved, what organs may be involved in that injury to your patient. Do they have a gunshot to the right upper quadrant? Were they kicked by a bull in the left lower quadrant? Were they kicked by a bull in the left upper quadrant? What is located in those areas? What are we going to have an index of suspicion as far as what organs are injured? So left upper quadrant, that's the spleen and the stomach. The transverse colon also comes across there. And then there's some small intestine up there in the lower left upper quadrant. Right upper quadrant, the biggie there, that giant organ called a liver that is a big blood filter that has an enormous blood supply to it. And if we have a major laceration to the liver, those patients are going to lose blood quickly. We need to remember that. We need to know what to look for there. Then left lower quadrant, that's descending colon. And then you have right lower quadrant's going to be mostly small intestine and a little bit of the large intestine, and then the appendix. There again is that division. The transverse line goes laterally through the umbilicus, and then you have the line that goes from the head toward the feet that divides the body into, it goes through the umbilicus. That's where you divide for purposes of assessment for those quadrants. Hollow organs. We have solid and hollow organs. Hollow organs, that's stomach, intestines, your ureters, your bladder. Usually those contain digested food, urine, fecal matter, the gallbladder, that would contain bile. That if those are ruptured or lacerated, they spill their contents into the peritoneal cavity. That causes an inflammatory response and can cause infection. Just the initial response to that fluid on the peritoneum, that lining of the abdominal cavity, that irritation can cause rigidity when you palpate the abdomen. So we're going to find this when we assess these patients. And then further down, the infectious process that causes peritonitis, that causes rigidity of the abdomen. And you have an infectious process that eventually can cause septic shock, and our patients will succumb to septic shock. Our job is to recognize it before it gets to that, get them definitive treatment. Number one would be to surgically repair whatever was injured. We provide stabilization and transport so that they can receive surgical intervention to repair what's damaged, and then receive IV antibiotics to address that infectious process that's going on in their body. That would be how the death from sepsis would be avoided, hopefully. There are arteries and veins that provide blood to the colon, to the small intestine, and to the large intestine, which is also called the colon. And those can be ruptured, lacerated. That can cause bleeding into the peritoneal cavity, and that can cause that rigidity that I was talking about. All right, that's just more anatomy, going right back to what we talked about in that human body chapter. Solid organs: liver, spleen, pancreas, kidneys. So liver and spleen are both big blood filters, and they have enormous blood supply. They also have metabolic functions as well, but for purposes of this chapter, it's just rich blood supply, and injury to those organs can cause our patient to bleed out quickly. Ruptured pancreas is really difficult to rupture the pancreas by itself. We're not going to really go deeply into what that causes, but the pancreas, if you'll remember, that's where insulin is produced. There are also other digestive enzymes that are produced there. The biliary tract connects to the pancreas. You have digestive enzymes produced there, and a ruptured pancreas can actually cause those digestive enzymes to start digesting organs in the abdomen. Come back for paramedic school and we'll talk all about that. Okay. Just like those chest wounds, these injuries to the abdominal cavity, injuries to the abdomen, those can either be open or closed. Blunt force trauma causes the closed, and penetrating trauma causes the open injury. And then they can involve either the hollow or the solid organs. Blunt force trauma, that's trauma to the abdomen without breaking the skin. You may have a big contusion to the skin. There may be abrasion to the skin. There might even be some superficial lacerations that go with that blunt force trauma. But the force of that trauma, that energy in the abdomen, that pressure can cause various injuries that we'll talk about. Mechanisms of injury that cause blunt force trauma. Oh gosh, tons. Your book mentions these. Maybe steering wheel for unrestrained driver, or maybe a restrained driver and improperly positioned seatbelt, or an impact that is so forceful that it drives the front of that car back to the point that the steering wheel impacts that driver. Handlebars from bicycles and motorcycles, being thrown from a motorcycle into a stationary object, falls. Oh gosh, I've seen people beaten with baseball bats, little pieces of 2x4, all kinds of things. It's just sometimes will amaze you, things that can be used to inflict blunt force trauma. A big hammer. I had a patient who was working in a shop and made this crazy guy in the shop mad, and he had a little, we used to call him a shop sledge. It's like a one-handed sledgehammer that weighs 3 or 4 pounds, and the crazy guy hauled off and popped the other guy in the right upper quadrant really hard with that shop sledge, that hand sledge, and caused a liver laceration. People never cease to amaze you, actually. Here's some discoloration. That's called ecchymosis, that kind of bruising across the abdomen that causes compression injuries. You can have a restrained driver in a vehicle that has a poorly positioned seat belt and have a rapid deceleration that can cause that that contusion across the abdomen with that ecchymosis. Uh, so it's a baseball bat. Again, like I said, I've had people who were beaten with baseball bats in the chest and in the abdomen, and have bruising like this on that abdominal wall, and we have a high concern that there are internal injuries that go along with that. Signs and symptoms of closed abdominal trauma, uh, pain. We're not talking, the pain that goes with this is what's called a visceral pain, rather than pinpoint pain like you have with a fracture, where patient could almost take one finger and point to the place that hurts the worst. This visceral pain, it's it it's like a dull pain that's spread out. It's not localized. That's the term we use, non-localized pain. It's a spread out pain. It's an achy pain. This visceral pain can refer to other locations in the body, such as a lacerated liver. Bleeding in the liver can cause pain that refers to the right shoulder. Left upper quadrant, uh, a ruptured spleen that can cause a diffuse, achy, visceral pain in the left upper quadrant, but it can also cause pain that radiates to the left shoulder. So, blood that irritates the peritoneum can cause pain that hurts throughout the entire abdomen. So we find those, we assess pain using the OPQRST acronym that we learned when we learned the patient assessment algorithm. So we have onset, we have provokes and palliates the pain, what makes it worse, what makes it better. Quality, is it an aching pain? Is it a dull pain? Is it a sharp pain? Can you put your finger on the place where it hurts the most? No, it just hurts everywhere. That would be that diffuse visceral pain. Or does it radiate anywhere? Well, my shoulder also hurts. Which shoulder? It's my left side hurts up there toward the top, and then my left shoulder hurts. Okay, we're getting somewhere. That's radiate severity on a scale of 1 to 10, with 1 being barely any pain and 10 being the worst pain you ever felt in your life. Where would you, how bad would you say this pain is? That's how we assess pain, and we use that tool with the assessment of abdominal pain. You can also use it with pain from thoracic trauma, but we don't have that much radiating pain, that kind of stuff with pain to the chest. It's still good to go through that OPQRST. Guarding, when you palpate the abdomen, it hurts, so they stiffen up the abdominal muscles. That's called guarding. And then abdominal distension, as blood starts to seep into that abdominal cavity and start to fill it up, then it starts to distend. It starts to have that puffy appearance all over. That abdominal cavity in an adult can sometimes, it can hold liters of blood. So I'm not going to make you memorize how many liters it could hold, but know that it can hold quite a bit of blood. It can hold enough blood that your patient can be in hypovolemic shock and on their way to decompensated shock and irreversible shock, because of that blood volume that can be held in that abdominal cavity. Look for that bruising or discoloration. May also have abrasions and then redness. That redness is called erythema. So if you hear that the patient had erythematous abdomen, that it would be red colored. We don't get that fancy in our language in EMT class. I do good to remember those terms, honestly. I just say uh, redness or I say that there's I might say ecchymosis. I probably wouldn't say bruising. I'd probably say ecchymosis, that bruising appearance. Seat belts are great. They save lives. Seat belts cause injuries. They cause blunt injuries. Sometimes they're worn too high, and it causes compression of those organs in the abdomen. It can do significant blunt force damage to our patient. Uh, it can seatbelt can it's important to restrain our patient and keep them in that patient compartment, but just like we talked about with deceleration wound injuries in the chest, you can have those same deceleration injuries, that third collision, the organs impacting the inside of the body. You can have those with even when a seatbelt saves a life. It can cause an injury that could eventually take the life, but we're more likely to be able to treat that patient and successfully transport them to a trauma center if we can keep them in that vehicle and keep them from bouncing around inside that vehicle, banging into other patients, toolboxes, baseball bats, uh, martial arts throwing stars. I don't know what you have laying around in your car, but it can become a projectile and a rollover or other car accident that could really cause some trauma to you. So be careful what you have laying around unless you want to be beaten to death with it. I wouldn't recommend carrying lots of knives and stuff laying around empty, loose in my car. I'm just funny that way. Uh, Bladder injuries, pregnant patients with that seat belt worn too high and not pulled down onto the pelvis, and uh, so that uh, so in a deceleration type injury, that seat belt, if it's too high, can actually rupture the bladder in a pregnant patient. There's pictures of incorrect positioning, pictures of the correct position. Strangely enough, uh, since this PowerPoint came from the publisher of your book, these pictures are in your book. Okay. Penetrating trauma, something from the outside pokes through to the inside, gunshot wounds, stab wounds, all of those things. Uh, we need to know what is in the area of that entrance wound in the abdomen. Why did I go with entrance wound? We need to look for exit wounds. We need to try to assess the path of a bullet going through the abdomen so we know where the entrance wound is, we know what the exit wound is, and we know what structures could be between the two. So we know things that are involved, liver that's going to bleed quickly, uh, gunshot wound through the stomach that angles over, and maybe it hits part of the liver. Just the stomach being penetrated is not going to cause massive amounts of rapid bleeding, but a stomach wound with that extends through the liver is going to have the potential to cause massive bleeding. Low velocity injuries, that's knives, rebar. What else? I've seen someone who didn't have a gear shift on their vehicle that had a floor shifter, rolled the vehicle, patient was unrestrained and stuck that gear shift through the abdomen and out the backside. That's a memorable call. I'll tell you about it sometime. Okay, medium velocity, that's small caliber handguns, like a 22 or a 25 pistol. The 22, I'm thinking of the like a 22 short that doesn't have a whole lot of powder behind it. It'll still kill you, but it doesn't cause the same cavitation on the way through that a high-powered rifle or a high-caliber handgun would. Shotguns, you have multiple impacts of medium velocity projectiles. With a shotgun, depending on how close the person is to the shotgun. If you have a patient who is shot with a shotgun from 6 inches away from their abdomen, that's going to appear more like a high velocity injury. High velocity and even medium velocity cause temporary cavitation. That is when the pressure wave that travels with that bullet, that energy after that round penetrates the body, that pressure wave going with that bullet spreads tissue apart. It tears it, it rips it, it sometimes just flat obliterates it, almost kind of explodes it, and then that tissue comes back together. The damage is done, but it goes back to the permanent cavity, which is just the path of the bullet, just the bullet itself going through. So, but temporary cavitation is that spreading and tearing of that tissue can produce large amounts of bleeding. Look for the exit wound. With high velocity, you could well see very extensive exit wounds, especially if that projectile was a hollow point bullet. So those flatten out when they hit, and so you have when it hits the skin, it starts to flatten as it goes through the abdominal muscle. It causes it to flatten out a lot more. That makes a larger permanent cavity as it goes through. Then you have the temporary cavitation, and then all of that comes blasting out the backside. So you have a wound that's bigger than the entrance wound, sometimes extensively bigger, and that can produce large amounts of bleeding. Sometimes those hollow points will fragment when they hit too, so you have multiple exit wounds. Just obliterates tissue. Low velocity, they have more of a direct path. They don't have a pressure wave that goes with them. That doesn't mean that they can't be quite lethal. Depends on where the stab wound is, where the low velocity gunshot is, but they can cause extensive bleeding. They can cause somebody to bleed out really fast depending on what they hit. Evisceration, that's when you have bowel protruding from the peritoneum through the chest wall to the outside. It's impressive looking the first time you see it. It's kind of a shocking thing to see. You start to inspect the abdomen and, oh wow, this is not a good deal. We don't try to put the eviscerated bowel or other organ. You could have other abdominal organs. It's just normally going to be bowel, but you have small intestine hanging out of the abdomen. We're not going to try to put that back in. We're going to visually assess it. We're going to put an occlusive dressing. We're going to put a moist dressing on top of it, then an occlusive dressing over that. We're going to seal that occlusive dressing. We do that so that if we had that stab wound or that caused that evisceration, if it lacerated one of the large blood vessels, then air from the outside could actually be sucked in to that vessel and create an air embolism. So we want, and then we also want to keep blankets over that. You're going to keep your potentially shocky patients extremely warm anyway, right? We remember that. but we're going to make sure we keep that warm. That keeps those organs warm. Have that moist dressing over that and then that occlusive dressing. Signs and symptoms of these open abdominal injuries, yeah, pain at the side of the penetration of the abdomen, and then possibly also from the exit wound. That could be a localized pain because it damaged a muscle. Then the organ that it damaged on the inside could also have a visceral pain that goes with it, like we just talked about. These patients can be in excruciating pain. Tachycardia, that goes with compensation for blood loss, right? Excuse me. Then we're going to look for evidence of shock. First, just like we always talk about, you'll see that the skin is going to be pale and diaphoretic, cool extremities because they're shunting blood through vasoconstriction. They're shunting blood back to central circulation, and then you have the adrenaline that's being released, that sympathetic nervous system, the adrenaline that's being released. Remember beta-1 properties, beta-1 receptors, that's going to cause tachycardia, increase the heart rate. It's also going to increase the contraction of the heart. So that's called an inotropic effect. It makes the heart muscle squeeze harder, trying to jack that stroke volume up so that compensate for that blood loss. And the respiratory rate's going to be faster, trying to get the most oxygen possible down there. That would come from, and then bronchodilation from the beta-2 effects of adrenaline, alpha effects, that's your peripheral vasoconstriction. All of those together are going to try to maintain perfusion of vital organs. And then as they bleed more, you start to see abdominal distension, and you start to feel, after you get about a liter to liter and a half of blood in an adult abdomen, it starts to feel firm. I'm not talking that rigid feeling yet. It just feels firm when you palpate it. And then after that peritoneum is irritated, then you get that rigidity of the abdomen and changes in mental status. At first, that patient's going to be apprehensive, and then as blood loss progresses, they may start to be confused, and then eventually unconsciousness. Hollow organ injuries, you can have delayed onset of the signs and symptoms. Maybe you have a high school kid playing football, and he's tackled, takes a vicious hit, and maybe it causes just a really small liver laceration. And other than the initial pain from that impact, there's no real abdominal pain. And then as that thing slowly bleeds, then those signs and symptoms can start to come on. Let's say there's a knife wound that just barely nicks the large intestine or the small intestine, and you start to get a little leakage of fecal matter, and that starts to irritate the peritoneum, and then as more and more leaks out, the bacteria proliferate, and you start to have infection, then you eventually, over time, start to see signs and symptoms of septic shock. Okay. Blunt trauma can cause hollow organs to pop and release fluids and air. ruptured colon from blunt force trauma to the abdomen, rupture small intestine, that can release enough air to actually feel subcutaneous emphysema when you palpate the abdomen. Very surprising when you find it, because you don't expect to find sub-Q emphysema in the abdomen. Penetrating trauma causes direct injury, like we've already mentioned. Gallbladder and urinary bladder spill the contents into the abdomen, and can have catastrophic effects. Interestingly enough, urine doesn't irritate the peritoneum, so you don't get that abdominal rigidity from urine, because it doesn't irritate the peritoneum. And air in the peritoneal cavity with a lacerated vessel could also cause an air embolism, because it could cause air to enter blood vessels in the abdomen and cause an air embolism. Bleeding could be rapid from an arterial injury. It could be a slow ooze. Your book calls it just a very slow bleed from maybe just a really small injury to say a mesenteric vein. Eventually that bleeding will cause abdominal rigidity, because it'll irritate the peritoneum, but early on you don't find that rigidity. And liver, patients can bleed out rapidly from a lacerated liver. Blunt force trauma to the right lower rib cage, to those can fracture those ribs. That can cause penetrating trauma to the abdomen that's not open to the outside. Nevertheless, you have a rib that slices through into the liver and can cause your patient to bleed out right in front of you. Okay, I already talked about the spleen and the pancreas. When is the spleen injured? Mechanisms of injury, I think your book's pretty accurate on this. Motor vehicle collisions, steering wheel trauma, falls from a height, landing on a stationary object, bicycle and motorcycle. Sound like my grandpa. Motorcycle accidents, bicycle and motorcycle accidents can impact that left side on the handlebars, on the way over the handlebars, and that can cause ruptured spleen or a lacerated spleen, whichever you want to call it. I'll buy either one. I've heard doctors talk about a fractured spleen before, and that was foreign to me, and then I thought it sounded cool for a while for me to say that, but none of our books use that. So then I started thinking maybe I just sound like an idiot trying to be pretentious and sound scholarly and sound like a better clinician than I am. So let's stick with a laceration or a rupture. Diaphragm. You can actually have penetrating trauma that punctures the diaphragm and get loops of bowel up into the thoracic cavity. These patients present with dyspnea. We may not find this pre-hospitally. I have had paramedics tell me that they had a patient with abdominal trauma and they were doing their physical exam and they were auscultating the lungs and they heard bowel sounds in the chest. And maybe so. I'm not saying they were lying. I have transported patients and found out later that my patient had a diaphragmatic rupture or a diaphragmatic tear, and that there were loops of bowel up in the chest, And I never heard bowel sounds in the chest. So, but I've had ER doctors and other doctors tell me that they've heard it. Maybe I just don't listen well enough. What I'll tell you about listening to bowel sounds, you have to listen for a long time to fully assess bowel sounds. So we just might not listen long enough to hear it. Maybe that's just maybe a shortcoming of mine. I don't know. Don't worry about it. Treat them for blunt force trauma, assess for shock, reassess for shock, and rapid transport. And if you don't find it, that's fine. Our job isn't to diagnose everything. Our job's not to diagnose this. Our job is to recognize life threats, treat them, call for additional resources when we need them for that patient, and provide rapid transport to the trauma center. All right. Kidney injuries. Those can come from both penetrating and blunt force trauma. The kidneys don't lie within the peritoneal cavity. We call them retroperitoneal organs. Let's talk about a mechanism of injury that's not uncommon on Friday nights in the Texas Panhandle. Violent tackle in football. Kid takes a helmet or a shoulder to the kidney, and that causes a contusion of that kidney, or maybe even it causes maybe it even causes a laceration of that kidney, and that kidney starts to bleed. That may be a slow bleed. It may not show up for a while. There's going to be flank pain, and then let's say the kid, they're tough. They don't want to tell anybody. So that football player goes home and he showers out and he gets dressed, gets on the bus, goes home. He's feeling kind of funny, and oh man, that flank's hurting. And he goes to take his clothes off so he can go to bed, and he pulls his pants off and he looks, and right there on his tidy whities, whichever way you say it. I just spaced out. Not uncommon for me. Right there on the tidy whities, he sees blood right there around where that urethral meatus is. And oh man, he freaks out. But he's also an adolescent. Adolescents are, I was an adolescent boy once too. My wife might tell you I still act like an adolescent at times. I still think farts are funny. There we go. We have it on tape. But adolescents are really self-conscious about their bodies and might go tell dad that, Dad, I just got undressed for bed, and I took that hit and it hurts back there on my low back, but I got some blood in my underwear, and then I had to go pee, and looks like there's a bunch of blood in the urine in the toilet, and I don't know what to do. Dad says, I know what to do. Call 911, get us there, and then we work through that mechanism of injury. And hopefully this is a slow bleed, and this is going to be treatable for this kiddo. Obviously, in my scenario that I just gave you, it is a slow bleed because he's still talking to dad and he's still walking around. So a good chance of a positive outcome. But let's say parents are gone for the weekend, or maybe single mom is raising this young man, and he doesn't like to go talk about his penis to his mom for sure, and doesn't really want to go talk about blood in his underwear. So he thinks, oh, I'll just take another shower. I'll get ready. I'll go to bed. He doesn't get up in the next morning to go to the Saturday morning film review, walk through, and rub out sore parts. Mom goes in, can't wake him up, calls us. We get there. We start to assess him. We ask her, what did he do last night? Played football. Anything happened? Yeah, he got tackled real hard, but he got up and he kept playing. And then when we start to uncover him, check him out, maybe even trauma strip him, whatever we're doing, oh man, we see this dried up blood in his underwear, and we look at that big contusion in his flank, and no wonder that he's unconscious and his blood pressure is 76 palpated and his heart rate's 130. We can't wake him up. He's bleeding on the inside. Good chance that kid's going to lose that kidney. Hopefully that's all that happens. Maybe he bled out even faster. Mom comes in and finds him dead in the morning. Those things happen. Hopefully we're going to get involved early enough that we can provide rapid transport and the surgeon can fix that. So there is a mechanism of injury. You can translate that to any other kind of blunt force trauma you want to. Okay, assessment of abdominal injuries. It may be obvious, it may be not so apparent to us. We need to look at the location of the trauma to the abdomen, remember what organs are there, and raise our index of suspicion as to what injuries may have been inflicted on those organs, and then provide the appropriate treatment and rapid transport. And then these things worsen over time. So our young man in my earlier scenario, we get there, his blood pressure, whatever I said, it's 86 palpated, his heart rate's 130, respirations are 28, and he's pale, he's diaphoretic. Now we're transporting. We're going to reassess him at least every 5 minutes. We're going to trim those vital signs, have ALS meet us during our transport if we're on a BLS truck. Call for a helicopter to meet us on the way somewhere. If we have a super long transport, but this kid needs a surgeon, trim those vital signs, reassess that patient, watch for deterioration in that patient over time. The more they lose blood, the worse their condition is going to be, obviously. You didn't need to come to EMT class to know that. Going back to our good old algorithm, scene size up, scene safety, same old thing as always. I'm not going to spend time on it. Mechanism of injury. What was the mechanism of injury? Is it a mechanism of injury that involves the need for spinal precaution, spinal immobilization? Then we're going to do it. We need to get non-rebreather mask on this patient. We need to provide the highest FiO2 that we can to the patient, closer to 100 to better. Maybe we need to provide positive pressure ventilation. Breathing is super shallow, it's irregular, and SpO2 is in the crapper, or if we're doing end-tidal CO2, that CO2 level's coming up because they're not blowing off that CO2. They're not exchanging CO2 for oxygen, so that CO2 level builds up in the body. That carbon dioxide, they start to get acidotic. The problems are compounding. This patient's going downhill, so we need to recognize it and get some help. Additional help. We are the help, right? But we need additional resources sometimes. Provide the most oxygen we can get to them. That rapid trauma, we call it. Your book sometimes calls it a rapid scan. That rapid trauma, looking for those life threats. These things can be subtle, so we need to trauma strip these patients, get down so we can see, feel, and smell what's going on here. If there's an abdominal evisceration, you can notice smell with it. Any open wound to the abdomen, you start to have that, not necessarily a fecal material smell, but it does have a particular odor when that abdominal cavity is open. Any of you who are hunters, or if you've been hunting and maybe somebody shot a rabbit and they skinned the rabbit, and when they opened the abdominal cavity, that's the odor I'm talking about. Okay, use that AVPU scale to check for responsiveness. Address life threats. Now, we can't stop this hemorrhage here. We talk about trauma as being a surgical disease, abdominal trauma especially. We can't put a tourniquet on it. We can't put direct pressure on it and do anything for our patient. We need rapid transport to a trauma center so the surgeon can get in and fix this. We can provide an airway. We can breathe for this patient. We are not going to stop this bleeding. We can treat for shock. That's the best we can do. We can call for ALS. They can, some places even infuse blood products, at least get some IV fluids in there to maybe help maintain blood pressure in the patient. But in the end, they need a surgeon. Maintain that airway, manage that C-spine, have suction available. We have to clear the airway. This abdominal trauma can cause nausea and vomiting, so we need to be ready to suction. And that abdominal distension, that can put pressure on the stomach, which can also cause nausea and vomiting. And then provide the maximum oxygenation that we can for them. Superficial abdominal injuries usually don't bleed that much. The internal bleeding is what we're really worried about. And what's the skin color? Are they pale or are they diaphoretic? Is their skin feel normal? Is their skin color normal? The temperature's normal. They don't look that bad. Then we're going to monitor these patients, reassess them frequently. They may not stay that way. They may bleed out internally and go downhill. The bottom line is, remember that platinum 10. We don't want to be on the scene with these trauma patients for over 10 minutes. So we're not going to stay on scene and play around and count the number of warts they have on their gluteus maximus. We've got to get scooting. The less time on the scene, the better, but we still need to do a good primary survey, get that rapid trauma done, and then provide the appropriate interventions at the BLS level, and then call for additional resources if we need them, intercept us on the way to the hospital or that helicopter to your scene. We need to be aggressive in that regard. Remember back to the golden period, used to be called the golden hour. We need to shorten the period of time involved in getting our patients from the time they're injured and we make first contact with them until they receive definitive care. We want it shorter than that hour. Why did we go away from saying golden hour? People goofed around and thought, well, I've got an hour. I can do all this stuff. I can sit here for 10 minutes and see if there are diminished bowel sounds or if there are hyperactive bowel sounds. No, we're not doing that. We need to shorten that period, that golden period, until we get them to an ER doc who can maybe they can do x-rays, they can get them to CT scan to look and see what kind of bleeding they have in the abdomen. They can even do the old, it's called a peritoneal lavage or a belly tap. They make a little incision and poke a catheter through into the peritoneal cavity, and they inject saline into the abdomen. Then they pull it back out with a syringe, and they look under the microscope to see if there are red blood cells in that. You don't see that done nearly as much. What you see done more and more, even starting to make its way into the pre-hospital realm, is the use of point-of-care ultrasound. You look and see if you have that the dense area that shows up as being kind of white where blood is in the abdomen. Those are getting cheaper and cheaper, so you're seeing them used more and more pre-hospitally. Okay. Investigate that chief complaint. Look for signs and symptoms of internal bleeding. Pertinent negatives. No abdominal distension. No abdominal rigidity noticed. That's a good thing so far, right? Patient denies abdominal pain. Even though there's a big contusion on the abdomen where they got whacked with the ball bat, we have those pertinent negatives. So those are important. Uh, and then OPQRST to assess the pain. Is there any nausea or vomiting? If it's been a while, is there any diarrhea that goes with it? What is the appearance of the stool? Is it a black tarry stool, that melana that goes with bleeding in the GI tract? Is it bright red blood that would be damage to the colon further down, more in the rectum maybe? It's not digested blood. Okay. Has the urine output gone down? Urine output goes down with shock. Has urine output gone down from a kidney injury? Is there blood in the urine? All those things are important for us. We're going to look for external bleeding. We're going to look for signs of internal bleeding. We're going to palpate for signs of internal bleeding, that distension, that firmness, then eventually that abdominal rigidity. Trauma strip them, keep them hot. Patients with abdominal injuries, you may find them lying on their left side with their knees pulled up to their chest because they have that irritation of the peritoneum, and it hurts to stretch their legs out straight, so they kind of curl up in a ball. That's frequently how you'll find them. Examine the entire abdomen, roll them over, examine the posterior side, look for any bruising to the flanks that might make you think that the kidney's been injured. What do we use? We use that good old acronym, DCAT BTLS, as we perform that head-to-toe assessment. When we palpate the abdomen, if they have a contusion to the right upper quadrant, we're going to start palpating at the furthest quadrant away from the injury. That would be the left lower quadrant if the injury's in the right upper quadrant. Then we want to compare the other side to it, so then we would palpate the right lower quadrant, then the left upper quadrant, and last you would palpate the location of the injury. Remember the possibility of radiating pain. Ask about that. Don't say, does the pain radiate to your shoulder? Ask, does the pain move anywhere besides that pain in your belly? Do you hurt anywhere else? Yeah, it's weird, but yeah, my shoulder hurts too. Oh, okay, which shoulder? All right, okay. Vital signs, get that good baseline set of vitals right off the bat. Use appropriate monitoring devices along with it. That would be your SpO2 monitor, and then if you have it available, your end-tidal CO2 monitor. And then we need to trim those vital signs. So every time we reassess, we're going to get another full set of vital signs so that we can monitor any changes over time. That gives us an idea of the stability or the deterioration of our patient. Those are important things to report to the hospital. And reassessment, we repeat those vital signs. I just said that. Why did I say it again? Well, I'm lazy. It's on the slide again, but let's say it again because it's important. We're going to reassess all of our interventions and treatments, and then we're going to maybe there was an abdominal evisceration, and we put that moist dressing over the protruding loops of bowel, and then we tape the. So where are we going to get this big occlusive dressing? We're going to use a multi-trauma dressing, that great big gauze dressing, gauze pad. We're going to use that on these abdominal eviscerations. We're going to wet that, put it over that evisceration. Now we need the occlusive dressing. Where in the heck are we going to get that? There is a plastic package that you just took the that big gauze pad out of. You can put that over the top of the that that gauze pad, that big gauze pad, and then you can take the 3-inch tape that you have on your truck and you can use that to seal all 4 sides in this case. So that's where you get that occlusive dressing from. You have to be creative. You're not going to have a big roll of sterile plastic on your truck, probably. The interventions, manage that airway, reassess the airway. If your patient's level of consciousness decreases, then we have to remember those airway adjuncts. Get that nasopharyngeal airway in, unless it's contraindicated. Get that oropharyngeal airway in. Oh, they don't tolerate the OPA. That's where I'm going first if I have an unconscious patient. At OPA, if their gag reflex is still intact, unless they have facial trauma in a multi-systems trauma situation, I can get that NPA in there and I can still ventilate them. I need to make sure that my NPA stays in place, right? And then we need to check our spinal immobilization, make sure no straps have come loose, all that stuff. Treat for shock. If you're not extremely uncomfortable, then you're not properly treating for shock. You need blankets on that patient, heater cranked wide open so that you look like you just climbed out of a swimming pool when you get to the hospital. Because remember what we talked about, that lethal triad of trauma. If you let that patient get hypothermic, that causes coagulopathy. What does that mean? The blood quits clotting as well, and that allows them to keep bleeding, and the body can't fight that. So that's what I'm talking about. You know that, but we'll say it again because it's a good thing to remember. The more times we say it, the more likely you are to remember it. Communication and documentation. Going to communicate all relevant information to the receiving hospital. What else am I going to report to the receiving hospital right off the bat when I find that I have this patient with serious abdominal trauma and this patient possibly has internal bleeding that may require surgical intervention on the end of that at that trauma center? We're going to call a trauma alert early on, whatever it's called in your jurisdiction. I used to call them red blankets. Now, for the most part, it's just called a trauma alert. You get on the radio, you say, Medic 12's on scene of a shooting. Patient has 45-year-old male patient with gunshot wound, right upper quadrant. Calling a trauma alert will report additional information as it becomes available. Boom! Now they can start mobilizing the cavalry. They start calling. Maybe they're calling that trauma surgeon to get him in the ER, waiting for you, or at least get him headed to the hospital. They get respiratory into the ER to maybe manage that patient on a ventilator after they get them in the ER and maybe have to intubate them. They notify local, maybe they notify the lab that they may need blood. They're probably going to keep O-negative blood there in the ER, and most trauma centers have that O-negative to use before they get a type and cross match. It also mobilizes that trauma team in the ER. Man, they're ready to play ball. They're standing in that trauma room ready to go to work when you walk in. If you don't call the trauma alert, they're playing catch up trying to get all the people there. Lab to draw labs right off the bat to get that type and cross match done for a transfusion. All those things. That's why you call a trauma alert. So don't forget that important piece that goes on the front end of what we've been talking about when you find these critical trauma patients. We can add that back over to that chest trauma lecture also, any of these trauma situations. All right, enough of that. You know what I'm saying. It's very important. On the radio, you're going to describe patients' injuries in enough detail so that they know what's going on with the patient. They know whether maybe they need to have a chest cutter in the ER, have that cardiothoracic surgeon there, or they need just a general trauma surgeon to attack that belly and ready to deal with that bleeding from that liver, whatever it is. Uh, paint a good picture for them. Maybe it's a multi-systems trauma and they have head trauma, they have chest trauma, they have abdominal trauma. We need to let them know that. Enough information to give them a clear understanding of what's going on to that patient so they can have all the right players there to take care of your patient. All right. If you have a patient trying to refuse transport, that tough football player with a little bit of blood in his underwear and flank pain, maybe dad saw him take that vicious hit to the flank, and kid gets home and dad goes in and says, son, are you having, let me see where you got hit in the back there. Oh man, or maybe it's somebody who's into martial arts, and my son and I were talking about this earlier. I used to do martial arts and really got into some really intense sparring there. I've told you before, we didn't have cable TV when I was growing up. We fought for fun. That carried into my adult life, even into my late 30s. I was taking martial arts and was in a fighting class and some intense sparring. And let's say I'm a tough martial artist, and yeah, I took an intense kick to my right flank, and I kept on fighting, and I get home and I've got flank pain, and holy crap, I got blood in my underwear and I got blood in my pee, and I just happened to say something about it to my wife, and then I want to go to bed and go to sleep because I just need to shake it off, need to get a little rest, drink a couple of beers, I'll be all right. Man, we're idiot guys. That's what we do. So, but my wife says, oh no, I'm calling the ambulance. No, you're not. I'm calling them anyway. You can call them, but I'm not going anywhere. And you happen to be on the crew that responds to idiot Buddy, the tough man martial artist who probably has a kidney that's bleeding, and you're trying to get me to go to the hospital. I said, I'll be all right. I just need to sleep. And you need to be assertive in explaining just what could happen. Look, you got this big bruise where you got kicked, you got blood in your pee, there's even blood on the inside of your underwear. This is going to keep bleeding, and if this keeps bleeding, eventually you're going to bleed out because there is tons of blood circulating to that kidney. You got to go get this checked out, because you don't want your wife to find a dead husband in the morning. You don't want her to collect that life insurance, and then she and her new husband will be living high on the hog, going on cruise ships and traveling to Jamaica once a month off of the life insurance money from you bleeding to death tonight. So this make me feel better, and let's just go on to the hospital, get this checked out. That kind of stuff. If it takes humor, if it takes being really assertive and saying, listen, you got to listen to me, but you have to try to convince these patients to go to the hospital with you. If not, convince them. If nothing else works, convince them to let someone drive them to the hospital, and even go so far as to watch wife get their butt out into the car and haul them to the hospital. So and then let the ER know, call them on the phone, say, hey, I just sent somebody your way. They refused transport. I could not talk them into it. If they're refusing transport, call the ER, call medical control, online medical control, and say, hey, I've got this patient with this person with this. He's refusing transport. Could you talk to him, doc, and tell him what might happen to him? I don't know. Just be assertive. Get some help. Try to talk them into letting you treat them, or at least talk them into being seen by a doctor. Okay. Patients require rapid transport to a trauma center for surgery, right? We've established that. Transport them in the position of comfort, which will often be on their side. If you don't suspect a spinal injury, transport them probably going to be on their left side, so they're facing you and they'll pull their knees up because that's the most comfortable. We're treating them for shock, just like we said over and over and over. Give them high flow oxygen. Don't withhold oxygen from these patients. Don't play around with the SpO2 monitor unless science changes right now we're going to provide all the oxygen possible to these patients that have this potential from developing shock from this. Have suction ready, just like I said, and that's what we're going to do. All right. Blunt abdominal wounds, we're going to look for that severe bruising. We're going to assess for that possible liver or spleen laceration, look for that discoloration, that referred pain, palpate for that rigidity of the abdomen. Let's see, what else haven't we talked about? A ruptured kidney, they're going to bleed out fast. What I was talking about before is a slow bleed. Maybe they have penetrating trauma and it impacted one of the great vessels. They're bleeding out fast. You can't fix that. They may not make it till a trauma surgeon can fix that. There may be nothing we can do. We're going to do all we can. We're going to try. Okay. If the situation is dictates that there may be spinal injury, then we need to go to that full immobilization with a cervical collar, backboard, and a cervical immobilization device with utilizing the full straps so that they are restrained on that backboard, just like we taught you in lab. And then monitor those vital signs. Open abdominal injuries we have covered. That's probably a moulage of an evisceration. Don't ever try to put the protruding organ back. Keep that organ warm and moist, just like I told you. Cover them with that moist sterile dressing, just like I talked about. We're going to add that occlusive dressing in there just in case. We're going to secure that with the bandage. In my case, I'm going to use 3-inch tape because I don't know that anything else is going to work very well. That's showing that occlusive dressing there. Okay, genitourinary trauma. Real quickly, I've covered renal injuries. Let's move on, and then that would also include injury to a ureter, injury to the bladder, injury to the urethra. Let's move on to male and female genitalia. Male genitalia, those are outside the body. Female genitalia are on the inside of the body. Okay, so male genitalia, things you might see. You can see gunshot wounds to the penis. I've seen a point blank gunshot wound to the penis of a man whose wife found out that she was not the only woman in his life. I mean, in the biblical sense. He came home drunk, passed out. She pulled her little .25 automatic pistol out of her purse. She pulled his underwear down. She grabbed his penis and she point blank shot him right through the shaft of the penis. He was no longer unconscious. He was no longer drunk. He was wide awake, in a lot of pain and bleeding and freaking out. She freaked out. That was before we had 911 in Amarillo, actually. She called 0 for the operator or 0. The operator sent the troops. We roll up. We go in, and sure enough, he is shot right through the penis. Long story that goes with this call that's pretty funny at times. Anyway, I'll leave that alone. What did I do? That was an isolated injury. I assessed him. He wasn't shocky. He was just upset, and he was in pain. I got a Surgi pad out, and I wrapped it around his penis, and I had him hang on to it to treat the external bleeding while I went on about my business. And that was how I treated that. Another one that I saw, little boy about 4 years old, wife. Yeah, he didn't have a wife at 4. Funny how that works. His mother was bathing him and his little brother. She finished bathing him first. She had forgotten to bring his little underwear in there. So she dried him off. She told him, run to your run to your dresser and get your underwear and put them on. He opened the dresser drawer. He's a little naked guy standing there. He got his underwear out and he used his legs to push the drawer closed. And he pushed really hard and he slammed his penis in there, and it it caused an internal rupture in his penis, caused a lot of internal bleeding. Uh, he was freaked out. Mom was freaked out. Uh, all I could do was put ice on it and transport him. These uh, injuries to the male genitalia, control bleeding, put ice on them to help reduce swelling, rapid transport to the appropriate receiving facility so that they can get a urologist to try to come treat this. It's going to be rare that you're going to have enough bleeding to cause hypovolemic shock from injury to penis, or to even to the scrotum and involving one of the testicles. Definitely needs evaluation and treatment at the hospital. Female genitalia, ran a sexual assault where it wasn't good enough to just sexually assault this woman. The guy took a knife and penetrated her with the knife and sexually assaulted her with the knife. She had massive lacerations to her labia. She had massive lacerations, I'm sure, inside her vagina. We don't inspect those things. We don't put a finger in there to try to evaluate those. She had a lot of bleeding from her vagina. Put a pad on the outside. When it would soak through, I'd put another one. Rapid transport, treat for shock. That is how I handled that. That's the appropriate way to handle that. Other ways that female genitalia are injured, you have, let's say you have a little girl on her brother's bicycle and she falls off the bicycle. She straddles the bar of that bicycle and it tears her labia, causes an external injury that's bleeding. If you respond to that, we're going to put something over there to control the bleeding, something like a Surgi pad. It's kind of like a Kotex, really, is what a Surgi pad is. It's a sterile dressing, and then we're going to put ice on that to help decrease swelling. That will also help with decreasing blood flow and hopefully help with bleeding. All right. Kidney injuries, I've covered backward and forward. We're going to keep on scooting. That's when we suspect them. An injury that causes an abrasion, laceration, contusion of the flank. All right. And then we've talked through the rest of what you might see. Fractures of the lower rib cage, or penetrating injuries to the lower thorax, upper lumbar region. We need to have a high index of suspicion that may also involve penetrating trauma to kidney. So we need to look for discoloration, hematoma, ecchymosis in the flank region. Okay, urinary bladder injuries, those are pressure injuries. That's why I don't drive with a full bladder. I try to make sure I always have an empty bladder when I drive. You will find patients who have a full bladder, they're in an auto accident, and they have that rapid compression in the lower abdomen there, right at the pelvis, and ruptures their bladder. It's a horrible injury. Okay. Deceleration could shear the bladder away from the urethra. In the latter trimester of pregnancy, the third trimester, then the possibility of bladder injuries increase. So pregnant women in MVCs, we need to assess for the possibility of bladder injuries. Boom, looks like that. Fractured pelvis can dislodge a piece of that pelvic girdle, that pelvic ring, and penetrate the bladder, males and females. And we'll talk more about pelvic fractures next week or the next when we do uh, musculoskeletal trauma. Fractured pelvis also has uh, a chance of lacerating uh, the uh, the femoral arteries and veins. It's actually the iliac artery, iliac vein that that branches off from the aorta and goes down through that inguinal area, this area right in here, and those pelvic fractures can lacerate those and cause massive bleeding into the pelvis. We'll talk more about that when the time comes. We've talked through that already. Amputation of a penis. One of my Actually, one of the first partners I ever had in EMS, I was an EMT. He was an experienced paramedic, meaning he was 2 years older than me, so he was 22. He had been a paramedic since he was 18. He started off working in Salt Lake, Utah. And he was 23. It doesn't matter. Anyway, there was a guy there that had mental issues, and he was a flasher. He was always flashing people, and apparently felt really guilty about it. Walked into a McDonald's one day, dropped his drawers, grabbed his penis, had a big sharp knife, and cut his penis off right there. Severe bleeding from that. Direct pressure, treat for shock, rapid transport, uh, and then treat that amputated penis just like you would any other amputated part. Wrap it in sterile gauze, seal it up in like a Ziploc baggie, a plastic bag, and then put that on ice. You don't put that amputated part directly on ice, but you package it up just like I said, and then lay that on an ice pack. That's what you're going to have is one of those chemical ice packs. Lay that on that, take that, and maybe a urologist can reattach that. I would think that's highly unlikely, but they'll give it a shot. Okay, I've already talked about that. Injuries to the external female genitalia because of that rich nerve supply, those are going to be really painful. And when there's a likelihood of sexual assault causing that, then we're going to need to, that is a reportable situation that we need to notify, and we need to notify law enforcement, call for law enforcement to respond to your scene or at least meet you at the hospital, and then manage that as we talked about previously with any other sexual assault. We're not going to insert anything into the vagina. We're just going to put those sanitary absorbent pads, what I called a Surgi pad, on the outside. High potential for embarrassment. Be professional. Provide privacy. We don't trauma strip these patients in the middle of McDonald's so that everybody in the world can see. Get them in the back of your truck so that there's privacy to assess them and treat them. Or if say they're at home and there's a bunch of people around, then you need to ask everybody to please leave the room, and then you can pull the underwear down to look for blood inside the underwear. Scene size up, scene safety hasn't changed. I think we've bounced around a little bit, but we've pretty well covered everything that we need to here. Oh, don't forget last intake of food and fluid. That's going to be important to the surgeon and the anesthesiologist if they have to go to surgery. Man alive, I think we have covered all of this. Pardon the silence. I'm just going to slide along this. An avulsion of the scrotum. Put a moist sterile dressing over that. Secure that, and with a sterile moist compress, secure that and transport the patient. It is also possible to, guys, we've probably heard of this, impact directly to the scrotum that can cause injury to a testicle, could even rupture a testicle, cause bleeding into the scrotum. That is a rapid transport situation. I need a surgeon to get in there and address that, put ice on it, and rapid transport. Rectal bleeding, we need to note if there's rectal bleeding, things that can cause it: sexual assault, foreign bodies in the rectum, hemorrhoids, ulcers, colitis. What color is the blood? How much of it is there? And then have those assessed at the hospital. We've talked about sexual assaults, 2 other chapters, so I'm going to slide right on past that. Often these patients are going to feel they're going to feel more comfortable with a same-sex clinician. If you don't have that, then be professional and make them as comfortable as possible. And that is the end of the chapter. Questions, comments, concerns, fears? All right. I will